Good morning, esteemed Presidium, organizer of the Congress, and dear colleagues. I'm honored to present a report of prevalence of anticoagulant therapy in patients with atrial fibrillation during stroke. Please, second slide. Next. Yes, okay, thank you. The Sergei Petrovich Botkin Moscow Multidisciplinary Scientific and Clinical Center, a large multidisciplinary medical institution of Moscow. It has a total bed capacity at approximately 1,700 and operates 19 research and practice centers. More than 100,000 surgeries are performed annually. The center employs 5,000 staff members, including 6 academicians of the Russian Academy of Science and more than 100 professors. They provide all types of specialized medical care and conduct scientific research, demonstrating the effective implementation of evidence-based medicine. The hospital offers round-the-clock emergency care and handles more than 1 million outpatient visits annually. It is led by academician of Russian Academy of Sciences, Doctor of Medicine Sciences, Professor Alexey Vasilievich Shabunin. We conduct a single-center observation study with consecutive enrollment and retropositive data analysis at the Vascular Stroke Center of the Moscow Multidisciplinary Research and Clinical Center named after Sergei Petrovich Botkin. Please, next slide. Hello, please, next slide. Oh, thank you. The study period was from April 2022 at April 2023. One inclusion criteria were adults aged 18 12 hours of the symptom onset, confirmed cardiac atrial fibrillation. Patient received oral anticoagulant therapy for more than 1 month prior to hospitalization, were analyzed separately. Please, next slide. Oh, please, next slide. Yes, thank you. Over 1,038 patients with ischemic stroke, 215, 20.7% had the cardioembolic subtype of the background of atrial fibrillation. More than half of them, 109 people, did not take anticoagulant therapy at the time of stroke. The study also includes on the 106% who took anticoagulants at the outpatient stage. Please, next slide. Next slide, slide 5 for characteristic patient. Yes. Thank you. The cohort of 106 patients taken anticoagulants and the outpatient stage had an average age of 77.8 years. The average CHA2DS2-VAS score was 6, indicating of high risk of stroke. Please, next slide, slide 6, for comorbid burden, please. Thank you. The study population present with a markedly elevated comorbidity burden, which directly contribute to the height in hospital mortality observed. Cardiovascular and metabolic complicating both anticoagulants management and stroke outcomes. Please, next for kidney function and dosing implication. Analysis showed that the majority of patients had reduced kidney function. More than half had moderate chronic kidney disease with an estimated glomerular filtration rate according to a CKD API between 30 and 59. This is critical for the correct because the CKD AP and Cockcroft Gold scores differ. It is especially important to select a dose calculation method that account for the specific characteristic of this population. Please, next slide, slide 8. Dosing, non-adherence, and historical context. Thank you. Our analysis revealed that in roughly 33.9% of cases, the prescribed doses of direct oral anticoagulants were not in line with clinical guidelines. Discrepancies include unjustified dose reduction, 50 patients on rivaroxaban, 15 milligrams once daily. 12 patients of apixaban, 2.5 milligrams twice daily. 4 patients with normal kidney function of the dabigatran, 110 milligrams twice daily. Below recommended dose of label dosing frequency to patient milligrams once daily. One patient on 10 milligrams, one antithrombotic therapy. In patient atrial 54% or physical unfollowed international guidelines. Yet no pattern, no patient received therapy pre-hospital. And only frequent on 1.5 years. Key challenges include warfarin dose adjustment, INR monitoring, bleeding risk, and high dog costs. Notably, in Russia, dogs for atrial fibrillation are provided free of charge of specific groups, including Moscow residents of 18 with atrial fibrillation. Patient with coronary disease, heart, and chronic heart failure with a left ventricular ejection fraction less than 40%, and certain beneficiary. However, despite resolved during provision, reduced patient adherence remains relevant today. Please, next. Thank you. Clinical outcomes. The mortality rate in our study research 30.2%. This significantly exceeds stroke mortality rates in the neurology department of Sergei Petrovich Botkin Center for Vascular Disease from 2021 to 2023. 10.4 to 11.8%, and is higher than data from National Register. The high mortality likely relates to stroke 77 severity. Half a patient had the National Institute of Health stroke scale, score of 8. Height comorbidity was majority has hypertension, chronic kidney disease, and 54.7% type 2 diabetes in 30.1%. Please, next slide. Slide 10, key takeaways and clinical implication. Please. Please take slide 10, key takeaways. Hello, Claire Brown. Next slide, please. Thank you. The study reveals several critical challenges at the management of atrial fibrillation and stroke prevention. Over half of the patients with atrial fibrillation cardioembolic stroke out of total cohort of 109 were not received anticoagulant therapy at the time of stroke onset, highlighting significant treatment gap and critical unmet need in outpatient atrial fibrillation management. Furthermore, in the in-hospital mortality rate research rate reached 30.2%, which reflect the combined impact of reserved neurological deficits, with the National Institute of Heart Stroke scale score of 8 of high observed in more than 30% of cases, and high burden comorbidities, including hypertension, chronic heart failure, and prior myocardial infection. Another key issue is widespread dosing non-adherence. 33.9% of patients received oral anticoagulant dose that did not align guidelines. The most frequent deviation involved unjustified dose reduction of rivaroxaban and apixaban, which likely contribute to breakout stroke. To address the challenge and reduce the risk of stroke recurrence in this high-risk population, it is essential to implement routine monitoring of direct oral anticoagulation plasma levels, conduct regular assessment of treatment adherence, and provide systematic education for patients and the families of the critical importance of strict adherence to anticoagulant therapy. I would like to express my sciences graduate to my scientific supervisor, Professor Denis Anatolievich Andreev from the Sechenov University Department of Cardiology, and academician for the Russian Academy of Sciences, Dmitry Alexeyevich Tychov, Director of Center of Predictive Genetic, Pharmacogenetic, and Personalized Therapy, who conserved the research idea and overseen the study. I extend special thanks for Associate Professor Maria Igorevna Chashkina from the Department of Cardiology of Sechenov University. I am deeply grateful to the team of the Vascular Center at Boskin Hospital for the assistance in data collection of the past year, as well as to hospital director Alexey Vasilievich Shabunin and first deputy Zurab Antonovich Bagatelia for the wise leadership and outpointing to work as well as part of a professional multidisciplinary team within this significant multi-center project. Thank you very much.
Good morning. Thank you for having us today. My name is Julia. I'm one of the clinical fellows in Southmead Hospital in the southwest of the UK. I am currently working in intensive care medicine, and I'm joined by Dr. Jack Dryburgh-Jones, who is an anaesthetist and resident doctor in the region as well. What we'd like to talk about today is emergency resuscitative thoracotomy course, and Jack will talk about the standards that we uphold during this course. So it's not moving with mics. So I would like to talk about the journey we've taken to set up this course. So the course is delivered by the multidisciplinary faculty. It was originally started. Has the slide moved for you or not? Sorry.
It doesn't look like it has, Julia.
Apologies for that. Okay, great.
Yep, great.
Awesome, thank you, Jack. So as I was saying, the course is being delivered by a multidisciplinary team. It was started by anaesthetist and cardiothoracic surgeon because they were involved in a case where an emergency resuscitative thoracotomy clamshell had to be performed. And what they realized is there's a regional gap in provision of a course that would train local people how to deliver this potentially life-saving intervention. We have delivered quite a few courses by now, and we are really lucky to be joined by more and more faculty members. We have over 20 faculty from a variety of specialties now, from intensivists to anaesthetists to cardiothoracic surgeons and A&E doctors, a lot of trauma network candidates as well. And we do this to sort of mimic the trauma team that would arrive at such situations in emergency department. So as I don't know how it works around the world, but what we get as a trauma call is that we absolutely get a surgeon, A&E doctor, a trauma lead, porters, anaesthetists, intensive care. A lot of people come together to wait for the patient, and we want all of those teams to be ready to receive such a patient and be able to make that decision to perform a clamshell thoracotomy in a timely manner as well. What we do on the day is that we do simulation moulages. So we run 7 simulations for our candidates. And we layered them with lectures about the guidelines that we follow to deliver this course and what the most recent research and data shows about timings and how to perform this, and also how do we connect regional hospitals. If a thoracotomy is performed in a small hospital, how can we connect these to tertiary centres where the ongoing care will need to be provided? We also ran a skills session, which is a dry lab station and a wet lab station where we suture sheep's heart. The aim is to provide access to training for frontline clinical staff who are very likely to manage such just trauma. On the course, we teach a lot of technical skills, but also we focus a lot on the non-technical skills, because we know from our experience and from the research that's out there that a lot of the communication breaks down during these really difficult and stressful situations, and this is where mistakes happen and delays happen, and this can be life-changing to the patient. And we continue to improve our course based on our feedback and the research that is coming up. The reason why we decided to do this course is because there's been a rise in stabbing injuries in the region. As you can see, there's been quite a few situations where a young person has been involved in a stabbing injury, and this can be really life-changing for someone who had the whole life ahead of them, and at the age of 15 or 20 they are stabbed in a park, and we couldn't save their life essentially because we didn't have the proper training, and sometimes even despite the training it is not possible, but we would like to increase our chances of saving them. These are just some of the news articles that we found. So when we look at the statistics for injuries that are knife-enabled crimes, so this graph shows us the children hospitalized for knife assault and knife-enabled crimes recorded by police by year. So it starts in 2013 and goes all the way to 2023-24. There was a decline in the crime and children being admitted to hospital because of COVID, because few people were around the parks. But either way, we can see that these crimes continue to rise. When we look at our sort of regional data, our region is Avon and Somerset, and we are not in the top 10, but we are number 1 when it comes to greatest increase of percentage of knife-related crimes, which means that we are dealing with these injuries more often, and we are not used to dealing them. So when it comes to the structure of the course, we work really closely with CARE. We use their accreditation and their e-learning and their handbooks, and they are sort of umbrella for the course. We also use the key algorithms and guidelines from European Resuscitation Council, and the STAG manual and Royal College of Emergency Medicine. So some of the photos from our courses. So the bottom photo is from our simulation suite, where we separate our candidates into 2 groups. One of the groups will do the simulation, and the other half will watch them through the screen and then deliver feedback during the debrief session. We are trying to stay as accessible as we can, which means that we don't have a high fidelity mannequins, but we do try our best with our resources, and it does mean that we can keep the cost down and keep this really accessible for everyone who wants to come on the course in the region. And as you can see, we also have some blocks of heart and lung where our candidates can practice suturing on RV injury and hilar injuries and other injuries that we can encounter. I'll hand over to my colleague Jack now.
Hello, yeah, thank you very much, Julia. So I'm Jack. I'm a resident anesthesiologist in the UK. I'm presenting sort of sandwiched between two night shifts on the labour and delivery suite where I work. So if I look a bit tired, it's because I am. And I'm sorry if I waffle a little bit, but we thought it would be useful just to talk about how we have made sure that the course that we run is as impactful and useful for our candidates as possible. We're teaching people to do a resuscitative thoracotomy, which is a high acuity but low occurrence event. And this might be a course that our candidates attend once in their careers, and it might be a procedure that they perform maybe once in their careers as well. So we really wanted to make sure that the day that we have our candidates with us for is as impactful as we can possibly make it. And to do that, we've tried to adhere to the ASPE core values. And ASPE stands for the Association of Simulated Practice in Healthcare. And they've released a really helpful document in 2023, which essentially lays the groundwork for what good simulation should be and how, as a faculty, we should be building our course and building our faculty to make sure that we are delivering it as efficiently as possible and as learner-centered as possible. Next slide, please, Julia. Thank you. I feel a bit like Chris Whitty saying that. Any attendees from the UK will know what I mean when I say that. So there are four core values that ASPE expects people to uphold when it comes to simulation. And the first one is safety. And the underpinning theme is that all simulation activities should be safe. And we address both physical safety and psychological safety within our course. We use sharps, we're using medical meat, we have live defibrillators, and we have to make sure that we address physical risks to attendees. And we have a sort of standard operating procedure for how we approach all of our risk-prone procedures. And that is kept with the course director on the day, and candidates can look through that if they have any questions. For example, pregnant candidates may not want to come into contact with the medical meat that we use for our workshops, but all of the information about the risks is there in a sort of paper binder that people can have a look through. And we make sure that we separate all of our simulation surgical equipment from surgical sets that will go back into circulation. And part of that has been that we've started to purchase our own surgical sets specifically for use on the course. But as well as physical safety, simulation needs to have underpinning psychological safety. And that is that we must uphold the basic assumption that every learner that comes to our course is intelligent, they're capable, and they care about doing their best and that they want to improve. So that learners who make mistakes during our moulages and simulations feel safe to do so and feel safe to debrief honestly with the rest of the team. And that is a expectation that we set right at the start of the day and continue throughout the day, is that people should be able to have psychological safety when engaging in simulation on our course. And that's an explicit basic assumption that we tell our candidates at the start of the day. Next slide, please, Julia. Thank you. The next core value is equality, diversity, and inclusion. And part of that is not just ensuring that we meet diversity and inclusion for the candidates that come onto our course, but also for the interprofessional faculty that teach the course. We very much want to be a resource for all healthcare professionals working across the southwest of the United Kingdom who might come into contact with patients who have been stabbed or undergone sort of blunt thoracic injury. And that is not just limited to surgeons, that's not just limited to anesthesiologists, that includes nurses, that includes critical care practitioners. And so we want to make sure that we are approaching our course with the same equality and diversity that we would expect hospital teams to demonstrate when they look after these types of patients. And to do that, we established a cross-system partnership so that we are making sure that sort of other staff groups are invited along to our course too. And part of that is that we have opened a nursing bursary. So in the United Kingdom, the government funds certain study budgets for doctors and some other healthcare professionals. And a lot of the time, nurses aren't included in that budget. So they have to pay for courses out of their own pocket. And we didn't think that that was very equal, that nurses should be asked to pay for something that doctors would otherwise have reimbursed for them. So we've created a nursing bursary to allow two emergency department nurses to come onto our course and learn alongside other healthcare professionals at no cost to themselves. And as I say, we've included an interprofessional faculty of doctors and nurses to make sure that we're addressing all of our candidates' learning needs. Thank you, Julia. The next core value is sustainability, not just with regards to the environment, but also how we run and plan for the future of our course. When we were developing this course from the ground up, we very much wanted to minimize the burden that we would have on the local environment by using reusable surgical sets, not single-use suturing sets as some courses often use. We reuse our non-contaminated equipment, so that's gowns, gloves, drapes, and anything that we can't reuse, we will try where possible to source from a clinical environment where it might have been thrown away. So, for example, a lot of cardiothoracic theatres don't end up using all of their sterile drapes for every case. A lot of those get thrown away. So we will repurpose those and bring them into the simulation environment. So at least the health system gets some benefit from them before it's inevitably taken off to landfill after a few uses. And we also make sure that we have appropriate disposal and recycling of our resources where possible. And to do this, we work with our simulation center to make sure that our recycling is correctly separated. And for our medical meat, these are pig and sheep mediastina that we need to safely dispose of. We have a standard operating procedure that we have created with the Estates and Facilities Department of the hospital that we teach this at. And they incinerate the medical meat safely and in a mindful way so that it is safely disposed of and doesn't come into contact with any human medical products. And then finally, excellence, and that is that simulation practitioners and organizations should strive for excellence through planning, reflection, research, and evaluation. And so at every stage of our course, so from our pre-course team meeting to our team huddles throughout the day to our post-course debrief, we're constantly challenging each other to think of ways that we can improve the course. We run a one-day train the trainer for faculty to make sure that all faculty coming onto the course have a baseline level of knowledge of educational theory, of adult learning styles, of how simulation is delivered on our course, and of how to use a structured debrief technique. And we use the diamond model of debrief on our course because we find that that gives the best opportunity for a facilitated conversation with our learners during our debrief sessions. We also challenge each other to improve our debriefing skills as well by completing a objective structured assessment of debriefing, or an OSAD tool. And this is something that we include in our portfolios and we reflect upon personally. And then we gather feedback from our candidates as well, from pre and post course feedback questionnaires. And we digest this, we create thematic analyses of feedback that's raised. And each of the several courses that we've run so far has included a sort of an alteration made based on previous feedback. So we're in a sort of constant quality improvement cycle with our course, and ultimately aim to make sure that the candidates that do have improvements that can be made feel that their improvements will be heard for the next course to sort of come through. Thank you very much, Julia. So that was sort of a quick whistle-stop run through the ASPE standards and how we have really built our course around those standards to try and make sure that we are addressing our learners' needs as thoroughly as possible and in as safe a way as possible. So thank
Perfect. So hi everyone, my name is Nika and I'm a core surgical trainee here in London, currently working at St George's Hospital. Today I'll be discussing a challenging donation after circulatory death heart transplant where the organ care system played a critical role in overcoming a catastrophic intraoperative complication. So reduced sternotomies in patients with durable left ventricular assist devices, otherwise known as LVADs, are inherently high risk, and there's an increase in the use of LVADs in the UK as a bridge towards heart transplantation. Structures such as the outflow graft and the ascending aorta may lie immediately behind the sternum, which puts them at risk of injury. Preoperative CT imaging is therefore essential to plan a surgical approach to minimize the risk of injury. This case highlights a pitfall with CT imaging and also demonstrates the value of the organ care system, otherwise known as the OCS, in extending preservation time during unforeseen operative delays and circumstances. So our patient was a 56-year-old gentleman with ischemic cardiomyopathy who underwent a HeartMate 3 LVAD implantation in 2022 as a bridge towards transplantation. After approximately 18 months on the waiting list, a suitable DCD donor heart became available. Importantly, preoperative CT imaging at this point suggested a relatively low re-entry risk. Prior to sternotomy, heavy ethibond sutures were pre-positioned across the sternum, as seen in the image here. This was done in case of potential catastrophic bleeding intraoperatively to allow for rapid chest closure. The team also prepared for rapid femoral cannulation if emergency bypass became necessary. During the final stages of resternotomy, there was an unexpected injury between the LVAD outflow graft and the ascending aorta. This resulted in major hemorrhage, and the pre-positioned ethibond sutures allowed for immediate sternal reapproximation and temporary hemorrhage control, while femoral bypass access was obtained. The patient underwent femoral cardiopulmonary bypass and cooling to 18 degrees Celsius for deep hypothermic circulatory arrest. The aortic injury was then isolated and repaired, followed by LVAD explantation and donor heart implantation. Importantly, the donor heart remained perfused on the OCS throughout this prolonged operative period. Despite the complexity of the case, the patient was successfully weaned from bypass with minimal inotropic support, and postoperatively he required a tracheostomy but made a steady recovery and was discharged home on postoperative day 40. So this case raises several important learning points. Firstly, preoperative planning is an important aspect of surgical training, and the preparation for safe heart and LVAD explantation begins at the point of LVAD implantation by ensuring the drive line and outflow graft be positioned away from the back of the sternum to protect it from injury on re-entry. Preoperative imaging is also a valuable tool for the assessment of the anatomical relationship between the LVAD outflow tract and the surrounding structures. Despite pre-op imaging in this case suggesting low anatomical risk, resternotomy was complicated. The findings at re-entry differed to what was expected on review of the immediate post-LVAD implant CT scan. On retrospective review of other imaging, anecdotal evidence of remodeling post-LVAD implantation is shown, including changes in geometry and the position of the heart and its surrounding structures. This may be attributed to anatomical changes occurring over time following implantation, adhesion formation, or the evolution of scar tissue. Therefore, singular static CT post-implantation may not adequately reflect the evolving nature of intrathoracic structures and increased risks of complications during re-entry. Further investigations are needed to determine the extent of remodeling that may occur in this setting. Another point of discussion is that preparation for catastrophic bleeding is essential in reduced sternotomies. In this case, the use of the strong ethibond sutures placed on either side of the sternum played a crucial role in managing a sudden hemorrhagic event at the time of resternotomy by allowing for rapid chest closure. This bought valuable time whilst femoral exposure was achieved to initiate cardiopulmonary bypass. Finally, the organ care system provided critical flexibility by extending donor heart preservation time. In donation after brain death, the use of cold storage means there is generally less flexibility for preservation due to ischemic time compared to donation after circulatory death. In this case, the OCS was vital in facilitating flexibility intraoperatively, addressing the time-sensitive nature of the transplant and especially accounting for the unforeseen complication. This contributed significantly to the transplant success. In summary, meticulous preoperative planning is vital in complex transplant surgery, especially given the progressive use of LVADs. Additionally, OCS technology is invaluable when unexpected intraoperative complications occur through extending preservation time of the donor heart and allowing increased flexibility intraoperatively. Finally, further research into the anatomical remodeling of intrathoracic structures post-LVAD surgery is required, and preventative means should be used to make LVAD explantation safer. Thank you for listening. These are my references.
Good afternoon with everyone. Thanks for the invitation to the scientist committee. So let's start to talk about anti-inflammatory drugs in coronary syndromes and update. Like introduction, as you know, cardiovascular disease is the most common cause of death in men and women worldwide. And something important to understand is the treatment of a complicated plaque when you have significant alteration to coronary flow. On the one hand, shows that patient condition has changed from chronicity to acute events, and it's important to consider a different treatment in early stages. This stage is called atrial inflammation. And inflammation is deeply related to the pathogenesis of ischemic lesions, fibrosis, and contributes to infarct size and the cardiac remodeling process. And inflammation in atherosclerosis is something of physiopathology. There are multiple pathways that can influence the atherosclerotic process. They can be influenced by different factors: infection disease, autoimmune disease, changes in the microbiota, tobacco use, medication, external and genetic factors. And different stimuli are activated that can lead to the activation of cells such as lymphocytes and mast cells, generating the expression of pro-inflammatory interleukins. As you can see in the graphic, there's many steps that conclude in the inflammation of the endothelial wall. The first stages contribute. The main causes are endothelial injury, abnormal lipid metabolism, and hemodynamic damage. The next step is endothelial cells are activated. They express interleukin 8 and E-selectin, P-selectin that can favorite the inflammation of the artery wall. And finally, many cells of cytokines are involved in the process, such as macrophages, T and B lymphocytes, dendritic, endothelial, and muscle cells that can be added to the endothelial wall. So the inflammatory vascular wall influences the pathogenesis and determines the evolution of the patient with unstable plaque. And there's inflammatory cells that can secrete proteolytic enzymes that tend to degrade fibrous plaque. And fibrolytic substance, together with metalloproteinase systems, can degrade the extravascular matrix and contribute to the plaque rupture. Finally, leukocytes can migrate. The leukocyte infiltrate in the atheromatous plaque, can produce proteases, inflammatory cytokines, and that can favorite the generation of thrombus formation and instability of the lesion. There's a graphic that can summarize the different inflammation pathways that I've already talked to you. So let's talk about the different trials that can be published in the many years since 2010. The first trial was called canakinumab Anti-Inflammatory Thrombosis Outcome Study. It involves 10,000 patients with prior MI. 3 doses of canakinumab were investigated, 500 and 150, and 300 milligrams were compared with placebo. The primary endpoint was the composite of non-fatal MI, non-fatal stroke, or cardiovascular death. With a median follow-up of 3.7 years, the incidence rate for the primary endpoint was 4.5 events per 100 person years in the placebo group, 4.1 in the 50 milligrams group, 3.8 in the 150 milligrams group, and 3.9 in the 300 milligrams groups. The conclusion of the study is that the 150 milligram dose, but not the other doses, meet the adjusted threshold for statistical significance for the primary endpoint. And the hospitalization for unstable angina leading to urgent revascularization was also statistically significant in favor of the use of this medication. The mechanism of colchicine is that it can interfere in the microtubule function, and finally they can inhibit the neutrophil function interference with the expression of selectins and neutrophil platelet aggregation, and finally it inhibits the inflammasome. The peak serum concentration occurs at 0.5 and 3 hours, and its effect is observed widely in 24 to 48 hours. Talking specifically in colchicine and the relation with chronic coronary syndromes was investigated with this first trial called LOROCO. It was a prospective randomized observer-blinded study. The follow-up was 3 years. The objective of the study is to determine whether adding 0.5 milligrams of colchicine to standard therapy for secondary prevention reduces the risk of cardiovascular events in patients with established chronic disease. The inclusion criteria: angiographically proven coronary artery disease, 35 to 85 years, clinically stable for 6 months, no major comorbidities, and the outcomes was the primary composite of acute coronary syndrome, fatal or non-fatal heart failure, non-cardioembolic ischemic stroke, and secondary is the individual components of the primary endpoint. This is the table of the study population. As you can see, the mean age was 67 years, and diabetes was present in almost 30% of the patients. Most of them were taking aspirin or clopidogrel, 95% of the patients. In this table, summarize the results of the trial. In the primary outcome, was statistically significant in favor of the treatment group. And when you see the individual components of the primary outcome, it was statistically significant in favor of reduced acute coronary syndromes, but it was not statistically significant in cardiac arrest or non-cardioembolic stroke. And when you see the individual components of acute coronary syndromes, the treatment can reduce non-stent related MI and non-stent related angina unstable. These graphics summarize the results that I already talked to you, and the conclusion of the study is that colchicine 0.5 milligrams daily in addition to high-dose statins and other standard therapy for secondary prevention appears to be effective in preventing cardiovascular events in patients with stable coronary artery disease. The next study is the LOROCO-2 in 2020. It's a randomized controlled double-blind study. It involves 5,500 participants. The objective is the same as LOROCO-1. The inclusion criteria: angiographically confirmed coronary artery disease or coronary CT angiographic, or a calcium score more than 400. 35 to 85 years, clinically stable for 6 months, and no major comorbidities. The outcomes of the primary is the component of cardiovascular death, myocardial infarction, ischemic stroke, coronary revascularization, and the secondary is the individual components of death, myocardial infarction, and ischemic stroke. The characteristic of the trial patients at baseline. And in this table, you can see the results of the trial. The primary endpoint was statistically significant in favor of the colchicine group. It can reduce the MACE, and the key secondary endpoint was statistically significant in favor of the colchicine group. In the first plot, you see the results. It can reduce the MACE, and in the secondary endpoints, it can reduce myocardial infarction, ischemia driving coronary revascularization, but it can reduce ischemic stroke, death from any cause, and cardiovascular death was not statistically significant in favor of the colchicine group. Conclusion: in patients with stable coronary artery disease already receiving secondary prevention therapy, the use of colchicine reduced cardiovascular events. And the inclusion of low-dose colchicine as a recommended therapy for patients with chronic coronary syndromes in the ESC 2024 guidelines marks a significant shift in the management of atherosclerotic CAD. So it represents an innovative approach reducing cardiovascular risk beyond traditional lipid lowering and anti-thrombotic strategies. So the recommendation of the guidelines is that in patients with chronic coronary syndromes, low-dose colchicine 0.5 milligrams daily should be considered to reduce myocardial infection, stroke, and need for revascularization. It is a recommendation 2A. And in acute coronary syndromes, the colchicine was investigated in the COLCOT trial. It's a randomized double-blind placebo-controlled trial, follow-up 23 months. And the objective is to evaluate the effect of colchicine on cardiovascular events and its safety profile in patients after myocardial infarction. The inclusion criteria: myocardial infarction within 30 days prior to study initiation, completion of any percutaneous revascularization procedure, and receiving optimal medical therapy, including high-dose statins. The exclusion criteria: people who have severe heart failure, left ejection fraction less than 35%, stroke within the previous 3 months, coronary artery bypass surgery within the last 3 years, recent or planned use of glucocorticoids, and chronic kidney disease or alcohol abuse. The outcomes: the primary is the component of MACE, and the secondary is the components of the primary endpoint, including atrial fibrillation, deep vein thrombosis, and pulmonary embolism. The characteristics of the patient is the same as the other trials. Participate 4,700 persons, and then it can see the result of the trial. The primary composite endpoint was statistically significant in favor of the colchicine group, and in the individual points, it can reduce stroke events and urgent hospitalization for angina leading to revascularization. It was not significant to reduce death or myocardial infarction. Adverse events: you know that the colchicine can cause nausea and flatulence. The conclusion: in patients with recent myocardial infarction, the use of 0.5 milligrams of colchicine significantly reduced ischemic cardiovascular events. The next study in 2020 is the Australian COPS randomized clinical trial. It's a multicenter randomized double-blind placebo-controlled study. Involves 795 participants. The objective is to see the effect of colchicine added to standard therapy for secondary prevention of cardiovascular events. Inclusion criteria: 18 to 85 years, and acute coronary syndromes and atherosclerotic disease defined as more than 30% stenosis in any epicardial vessel demonstrated by coronary angiography. The outcomes: the primary is the composite of MACE, and secondary components of the primary endpoint and hospitalization for chest pain. They exclude the participants that have indication of coronary artery bypass, chronic use of colchicine or immunosuppressive therapy, several renal or hepatic impairment, and active cancer. The characteristics of the participants, and it has a controversial result. At 400 days of follow-up, the deaths from any cause were more in the colchicine group. The most causes of death was infectious. In conclusion, in patients with acute coronary syndrome, the use of colchicine did not significantly reduce cardiovascular events. And I'm going to talk right now about a meta-analysis of randomized controlled trials. The objective is to see the efficacy and safety of colchicine in secondary cardiovascular prevention in patients with CAD. It involves 79 studies, including the low record 1, 2, COLCOT, and COPS. The inclusion criteria: is the comparison of daily colchicine use against placebo for secondary cardiovascular prevention. The study had to report at least one of the following outcomes: cardiovascular death, myocardial infarction, stroke, heart failure, or urgent revascularization. Patients in both groups had to be receiving standard therapy, and the minimum follow-up is 1 year. These are the results that I already tell you. The results of low-code, cold-coded COPS, and low-code 2. The forest plot demonstrates the results. The primary composite endpoint of MACE was statistically significant in favor of the colchicine group, and in the components of the primary endpoint, it can reduce cardiovascular mortality, but it was not statistically significant. But the individual endpoint that was statistically significant was myocardial infarction, ischemic stroke, and urgent coronary revascularization. So in conclusion, patients with CAD, the addition of low-dose colchicine to standard therapy reduced the incidence of major cardiovascular events. With the exception of mortality, significant reductions were observed in myocardial infarction, stroke, and urgent revascularization. And the most important trial in acute coronary syndrome is the CLEAR Synergy OASIS-9. The objective is to assess the impact of low-dose colchicine and spironolactone in post-MI patients who undergo percutaneous coronary intervention. It involves 7,000 participants with acute myocardial infarction having a percutaneous coronary intervention. So the randomization was within 72 hours of PSI, and the design was 2 by 2 factorial randomization, stratified by MI with ST elevation versus no ST MI, and the groups that conforms the trial was colchicine placebo plus spironolactone placebo, colchicine active plus spironolactone placebo, colchicine placebo plus spironolactone active, and colchicine active plus spironolactone active. It was a maximum of 5 years of follow-up, and the primary outcomes was colchicine against placebo, time to event composite of cardiovascular death, recurrent MI, stroke, or unplanned ischemia driving revascularization, and the spironolactone versus placebo. The co-primary one is the total composite events of cardiovascular death or new or worsening heart failure, and the co-primary is time to event composite of cardiovascular death, recurrent MI, stroke, or new or worsening heart failure. It involves 104 sites in 14 different countries since 2018 to 2022. In the graphic, you know that it was no statistically difference in the colchicine group. In the individual endpoints, there was not difference in colchicine and placebo group. So in conclusion, the current data represent the largest randomized assessment of colchicine in acute MI and fail to demonstrate a reduction in MACE or its component endpoints with extended follow-up to 5 years. So the ACC to 2025 recommendation remains a class 2B recommendation. They say the low-dose colchicine may be considered in select patients after acute coronary syndrome to reduce the risk of recurrent ischemic events, provided there are not contraindications. And in contrast to European guidelines, the AHA is more cautious due to the results of the CLEAR Synergy OASIS-9 trial. And talking of other medication, the allopurinol, it was investigated in 2010 by normal ET. The double-blind randomized placebo-controlled study involves 65 participants, demonstrate that high-dose allopurinol may possibly prolonged exercise capacity in patients with chronic stable angina. And in 2017 was investigated the therapeutic effect of allopurinol treatment in acute coronary syndromes. So the total effective rates in the allopurinol group were much higher than in the control group for angina pectoris, and the incidence of cardiovascular events during 2 years of follow-up in the allopurinol group was 10% compared with 30% in the control group. And the only multi-center prospective randomized open-label blinded endpoint trial was the Heart. It includes patients more than 60 years with coronary artery disease. They were randomized into 2 groups, one of which received allopurinol in addition to usual therapy, and the primary outcome was a composite of non-fatal myocardial infarction, non-fatal stroke, cardiovascular death. A total of 5,700 participants were included in the intention to treat population. The mean follow-up is 4.8 years. The results showed no difference between the groups in the terms of the primary outcome, and 30% of participants discontinued the treatment. Another one is the methotrexate. It was investigated by the cardiovascular inflammation reduction trial. It's a randomized double-blind placebo-controlled study published in 2019. The objective was to evaluate the impact of methotrexate or secondary prevention of atherothrombotic events in patients with a history of myocardial infarction or multi-patient coronary artery disease who also had type 2 diabetes or metabolic syndrome. Low-dose methotrexate was tested versus placebo in 4,000 patients. And the original primary endpoint was a composite of non-fatal myocardial infarction, non-fatal stroke, or cardiovascular death, and the results were not statistically significant for the primary endpoint. And finally, the tocilizumab is an interleukin-6 receptor antagonist. There's a trial in 2016, a placebo-controlled double-blind trial that involved 117 patients with non-ST segment elevation myocardial infarction who were randomized to receive placebo or a single dose of tocilizumab before coronary angiography. CRP and high sensitivity troponin tip were subsequently measured, and the values were 2.1 and 1.5 fold lower in the tocilizumab group respectively. And the only randomized double-blind placebo-controlled trial is the SAIL-MI, published in 2021. Was conducted at 3 high-volume percutaneous coronary intervention centers in Norway, and it involves patients with ST elevation myocardial infarction within 6 hours of symptoms onset were enrolled. A total of 100 patients were randomized. And myocardial salvage index, assessed by cardiac magnetic resonance imaging, was evaluated after 3 to 7 days. And the myocardial salvage index was significantly higher in the tocilizumab group compared with the placebo group. There was no significant difference in the final infarct size. The conclusions of the speech is that the importance of discussing and studying how to prevent the onset and progression of atherosclerosis through anti-inflammatory and immunological regularization. Drugs targeting inflammatory mediators such as canakinumab have confirmed the inflammatory theory of coronary heart disease, and classical anti-inflammatory agents such as colchicine have demonstrated the possibility of feasible clinical use. And colchicine has been included in the guidelines of Spanish Society of Cardiology as a possible indication in chronic coronary artery disease and post-acute coronary syndromes. Thank you.
Mechanical circulatory support and transplantation in adult congenital heart disease, which has become a really a most advanced issue in recent days because of the success of the pediatric cardiac surgery So the population, adult congenital population, is growing continuously. I don't have any disclosure to have myself. So to give an idea of what the ongoing problem, and now more than 90% of the children born with the congenital disease will survive in adulthood. In 2005, the CHD population, the adult outnumbered the pediatric CHD population, and estimating more than 1 million adults in US alone with the congenital heart disease. And also adults with congenital disease live longer than it used to be, and from the median age of 37 years old in 2002 to 57 only in 2007. So big step forward. And more improvement has been seen particularly in those adult congenital heart disease with severe disease. And the median age of death has dramatically increased from 2 years before 1995 to over 25 years now, with a rapidly growing population with more complex congenital heart disease, particularly single ventricle, coronary defect, and this also adult congenital face continuously cardiovascular issue and need for advanced cardiovascular therapies. And because these patients present unique challenges, they need to be evaluated in properly developed center with the specialists in adult congenital heart disease. Now, this is just summarizing the burden of the disease. And this is a registry, particularly in Northern Europe. But I want to just focus for you, particularly in the top left, where you can see there are just in the United Kingdom 1,600 new adult congenital patients each year. And also at the bottom right, you can see how the particularly adult heart failure is one of the major lead causes of death in adult congenital heart disease. So heart failure, the mechanism can be related to the underlying anatomical defect, to residual lesion. They can create a volume of pressure overload, systemic or pulmonary hypertension, cyanosis, because cyanosis per se or low saturation may cause a chronic effect on the liver, kidney, and other organs. Now, heart failure mechanism, we have to also remember myocardial ischemia from either supply or demand mismatch, coronary anomalies, arrhythmias, dysynchronies, chronotropic incompetence, which can be related to the world of arrhythmias in general. So, very important to have a service for assessment and management of adult congenital disease with a patient selection, transplant, and when the patient is selected for transplantation, needs to be an optimization and transplant list to make patient to survive when they are on transplant list, and a prevention of death after the transplant. Consider alternative surgery, converting patient not transplant candidates to be transplant candidates, and mechanical circulatory support as an intermediate stage, as a bridge to transplantation. Now, the heart failure is a big theme in adult congenital disease and needs to involve the pediatric heart failure transplant cardiology, the adult congenital cardiology, the congenital cardiac surgeon, transplant surgeon, cardiac anesthesia with the expertise in adult congenital disease, intensive care, but don't forget particular single ventricle because of the compromission of the kidney and particularly the liver, to have a nephrologist and a pathologist involved in the discussion, particularly with the Fontan failure. So preventing death follow assessment is very important that we consider alternative surgery and alternative strategies. In this sense, the VAD and ventricular assist devices has now become the most obvious mean for these patients. And particularly because with the VAD, we can support patients and to become also transplant candidates. And we shouldn't forget also the possibility to heart transplant, not very common these days. Myself have done basically 2 in the last 10 years, so it's very rare, but still need to consider in some patients if they are good candidates. I want to focus on 2 things. I want to focus on the dysfunctional systemic right ventricle. When we have a systemic right ventricle, 2 major diseases. One is basically those patients that the transposition of the great arteries, and many years ago, before the development of the arterial switch, we were corrected with so-called atrial switch or atrial correction for transposition. And we know that this right ventricle in systemic position at the end of the day, after some time, is going to fail. So this is basically systemic RV has got high risk for long-term failure and increase with age. Normally, the dysfunction usually precedes the clinical heart failure, and the symptoms are strong predictor for mortality. This basically was a nice review by these two very, very important cardiologists. Lucy Roche worked with myself in Newcastle, and Dr. Reddington is a fantastic, brilliant cardiologist in Canada. They published this where they look at the possibility of medical treatment of patients with systemic RV. And none of this medication seems to work in a systemic RV. And also, why this medication do work? Probably because they're wrong targets, because the right ventricle is profoundly different from left ventricle, from the anatomy, different contraction, different RV pressure volume loop, the present tricuspid valve, which basically sometimes got Epstein malformation, and also for previous surgical procedure. We shouldn't forget the right atrial baffles during the atrial transposition, atrial correction, they are very rigid. They don't allow some kind of distension of the atria. So there is an inability to increase the stroke volume and the cardiac output after the atrial correction. What's the other option for this patient? Electrical therapies. I know CRT is being used in prevention of systemic dysfunction or implantation of ICDs. Or conventional surgery, sometimes with an anatomical repair, when it could be done, tricuspid valve repair replacement. Pulmonary artery banding was basically developed to let the shift of the septum in a way to basically help the function of the ventricle, but particularly transplantation and mechanical support. So during my time, I've done 19 transplants of patients with systemic RV and two ventricle physiology. The median age of the transplant was 24 years. There were patients with 6 sendings and 10 masters. Both of these operations, for people that maybe not knowing about the both atrial correction of the transposition. And there were also the 3 CCTGAs, which are congenital correct transposition, unoperated or after a physiological repair. Physiological repair is when basically we connect the ventricle in the same fashion they are basically born, so the right ventricle remain in the systemic position. And all alive at the recent follows up. Now, there also we implant, when I was in Newcastle, a large number of patients with systemic RV, and this is the paper we produced. We have 7 patients with just 1 death, and most of them they're transplanted, which some of them they've been recently transplanted. Now, this is very nice, show the position of the VAD. On the left, you can see the VAD in a patient at the master of the operation, means atrial correction. You see the VAD seems to be in a very funny position, but actually that is the right ventricle, which is in systemic position. So the VAD is on diaphragmatic phase of the right ventricle and in systemic position. On the margin on the right, you can see instead the patient with the congenital correct transposition. In this patient, the ventricle are side by side, not one at the top or one at the bottom, and this on the systemic RV. So this is show basically that these devices, particularly the new generation HeartMate 3, have got a great decrease in incidence of any neurovascular events, particularly stroke, and the incidence is very, very decreasing compared to what we use in the pediatric population. So in pediatric population, we used to use the Berlin Heart, and this is 2 trials, one done in States. The stroke was 29%, done by us in England. And this is a combination of what happened in Newcastle and a Great Ormond Street. The incidence of stroke is still high, a little bit less, but still a quarter of the patient develop a neurovascular event. So basically, we look basically at this group, and we see that the stroke and neurological dysfunction regardless and comparison proportion, is still very high with these new devices, basically. So what do we start to do? We start to implant adult devices in a pediatric population. And this is one of the patients, probably is the youngest and the smallest patient we implant an hardware. The hardware is no more available on the market for some dysfunction. And this was a child with basically myocarditis, where we implanted these devices inside. The heart recovered, and basically the patient device was removed. But this was the child. And this other lady instead is a child which I've done when I was in the United States, in Minnesota. This basically is a girl who had a very bad osteosarcoma on the knee. She was treated with aggressive chemotherapy. She developed heart failure, and then we implanted hardware. And hardware stayed there for 2 years, where she had all the treatment for the cancer. And then eventually, when the cancer was basically deemed completely gone and not recurrent, she was transplanted successfully. We should this and we extended this role of the continuous flow device in pediatric population. And so in many patients, we implanted this adult because of the incidence of the stroke. And this is very important. And one of the most important things is the development of the HeartMate 3, which is wider blood flow passage inside the pump, no touching parts, and what's intrinsic pulse. So there's a washer pumps to prevent clot behind the aortic valve. This was a gentleman, Ulf Kjellman, who introduced me to the HeartMate 3 when I was in Saudi Arabia in 2000 and from 2016 to 2018. We were one of the first center in the world implant the HeartMate 3 on compassionate ground. We done in many patients when I was in Saudi Arabia, and it was very, very good success. So which basically increased the usage of the VAD, as you can see, during the following years. And this basically shows exactly the organ allocation in adults with congenital disease listed for transplantation related to the usage of the VAD compared to the population. And you can see how many patients now are assisted by VAD, even in an adult congenital population. This is a major, for me, major argument, major subject, because a single ventricle now has become maybe the leading problem for this patient. And this is basically just to remember the pathophysiology, the pulmonary of the Fontan circulation, which is a non-passive flow through the lungs in the single ventricle, which can be a pump failure or AV valve regurgitation with systemic venous hypertension, endothelial dysfunction, and systemic hypertension. Of course, mechanism of failure can be a delay in a primary palliative strategies, structural defect, particularly the heterotaxia and ventricular dominance, and also anatomical physiological effect of the Fontan, like a loss of the sinus rhythm, pulmonary stenosis, atrial enlargement, AV valve regurgitation. And also the sequelae of the Fontan, like the chronic underloading of the ventricle, because actually the ventricle is underloaded, protein-losing enteropathy or plastic bronchitis, cardiac cirrhosis, collaterals, venous collaterals, arteriovenous malformation, and pulmonary vascular disease. What the mechanism? The mechanism can be a pure pump failure, means the ventricle doesn't work, or circulatory failure, which is basically where the circulation is caused pulmonary hypertension. So the Fontan circulation is basically working on very high pressure, or the combination of the two, which is very common. So what is the last step before transplantation is basically sometimes to convert some of the old-fashioned atriopulmonary connection in total cardiopulmonary conversion with also some arrhythmia surgery. Personally, I think indication arrhythmia and mechanical obstruction remain the only viable indication at the moment for this big operation, because most particularly is not the easiest operation in some cases, and there's larger uses of blood and blood products, which increase the antibodies. VA ECMO has been also something very used particularly in acute failure. and as a bridge to decision or bridge to transplantation, and help in cases where there is also respiratory failure. And this is basically some slides which I take from Dr. Konstantinov on the seminars of cardiac surgery as what we do in terms of VAD in a single ventricle. This is two possibilities with the right side on the Berlin heart or with an heart matrix. And this depends on the age of the patient, of course. And this is basically shown by a group in Edmonton and basically show exactly what we could be done in terms of assist device in right on the left side of the heart. And this group particularly very important because what they've done is they select for each group of the patient, depending on the systolic, diastolic dysfunction, what could be related to the weight of the patient, the best of the device. And of course, we can see that there is also consideration for some patient to have also total artificial heart, particularly now they develop a 50 cc chambers, which is much smaller and can be used in these patients. And that is exactly what I'm talking to you. This is the total artificial heart now, which is available also not just 70 cc but 50 cc, which can be basically implanted. Just to say that the implantation of the total artificial heart sometimes is not easy, and don't forget that many of these patients have also anatomical difference like a dextrocardia, position, the vessel can be very different. So this operation can be highly challenging. This is what we see what happened with the VAD support in Feli-Fontan. And this basically show a competing scheme of what's happened with this patient. And we have to say that a study which I've done myself, I'm still completing, over the years, since we start to implement some VADs in this patient, and we took in 1988, the overall survival of VAD support in a single ventricle is around 50 to 60%. And I have to say, there's no change in the recent years, although there are many more patients supported like this. But again, the success is not exactly as we do with the two ventricles VAD. This is a case which I've done myself in Minnesota. This was an heart matrix in a Feli-Fontan. We've done a 3D reconstruction before to implant to make sure there was in a position. This patient had a single ventricle for hypoplastic left heart syndrome, and this VAD is inside the right ventricle. And this basically shows the reconstruction 3D, the X-ray after the operation, and this basically the echo show the mouth of the VAD inside the right ventricle. It is also the VAD performance over the time. Of course, this guy made a very nice paper regarding what will be the effect of continuous flow instead to have a pulsatile flow. And he said what will be the problem. The problem, of course, sometimes is related to the non-pulsatile flow in the peripheral organs. And this basically talk about the lungs, the renal, the abdominal organs, particularly the liver, which needs to be considered. So when we have these patients coming to us for transplantation, we have to think as a surgeon the complexity of the anatomy. We look at the position of the heart, the venous return, presence of collaterals, what would be the previous cardiac surgery. Sometimes we don't know they've done some repairs, maybe repairs many years ago, maybe the operation not then go lost. And we need extensive imaging, which include the CT, MRI, cardiac cath, and so on. Sometimes they have lots of previous sternotomies, so there are lots of additions. And also we have to make sure there is a patency of peripheral access in preparation, a potential mechanical support, comprehensive hematology review. Most of these patients are on anticoagulation drugs, precise assessment of the liver and kidney, particularly as end organ, and also look at the previous surgical documentation. So we have to look at the hematological issue and considering basically this patient may on Coumadin, aspirin, or the new anticoagulation drugs. The look at the chronic but subtle liver dysfunction, and also prepare nitric oxide and other agents suitable for decreasing pulmonary vascular resistance. Also consider gut decontamination for colomycin, which should include in bypass circuit, and the strategy as antibiotic prophylaxis. I have a philosophy that this patient needs a very big heart, normally very young hearts, male hearts, and with a short and ischemic time, with a plenty of ascending aorta, and make sure that there is plenty of inferior vena cava, pulmonary artery for complex reconstruction. One of the problems is antibodies, because the usage of lots of patches during the life of these patients, and so they develop antibodies. So you can see, and this was showing what's happening in recent days, the PRA, which is the panel of reactive antibodies, in a different era is gone up very much to reach almost 20%. So 20% of the patient cannot be transplanted immediately on the first donor because of the presence of antibodies. So this is my strategy, operation brief, use of cerebral saturation, what to use for bypass, which is high flow, how we manage the pH strategies, addition on cardiopulmonary bypass on mannitol, and consider hot shots. This is again something regarding my philosophy. Don't complete the stent of the pulmonary artery, leave IVC Fontan graft if present. If a left SVC, connect with the Gore-Tex graft and so on. And basically, if we have very rarely this old-fashioned Fontan, be careful in dissecting the homograft, normally very close to the sternum. And again, this what we do with the graft, leave basically a hole inside the heart to decompression and the drugs to be used after. Particularly very important for you and to say stress the use of nitric oxide inhaled prostacyclin up to 5 times a day to decompress the pulmonary circulation. And this is kind of, again, Dr. Kostadinov put also his exercise in what we're doing for transplantation in these patients. And basically this showed the number of the patient will be done in United States and this increasing population. Now the problem will continue, the congenital disease will continue to increase indication, and there is a very high 30-day mortality in some of the patients because, and this will show exactly what happened within 1 year by diagnosis. And the congenital heart disease basically is the yellow line. Okay, but if we take this and we exclude the first year where the most of the patients, particularly Fontane, may die, actually the congenital disease are the best long-term survival. And this is shown in our case in Newcastle. This was a comparison, not just the survival, but also by area. And we see that we're getting better. And this is very important when we compare, particularly the pediatric Fontan, because adult Fontan is not a simple operation, the cardiac the transplantation, and this is the difference compared to the pediatric Fontan transplantation. And again, this will show also now the center, and this coming from Mayo Clinic, and you see the higher basically level of mortality in these patients. This was the very poor results he had in the past many years ago, and this was reported in different parts of the considering one was from Italy, one was from Loma Linda, the other one was from Philadelphia. So very big unit. Still, the outcome, the mortality, very high. And this was a survivor from a Fontan transplant, which by here, as you see, this was our cases in Newcastle. It was a major increase in an area between 2002 2013. And looking, the mode of failure was mainly related to transplantation, was non-Fontan compared to the Fontan. But once, you can notice here, once the patient has gone the first month, the mortality action is better than the other groups. Let me tell you something very quickly regarding the liver, because now in the Fontan, the assessment of the liver and the liver fibrosis with the ultrasound scan or scan is very important. So liver fibrosis is considered one of the liver failure considered one of the most cause of death in Fontan transplantation. So, and this is very important for us to go back to assess the fibrosis and have the hepatologist involved. If a patient is only only a single lung or heart and liver transplant. So when increased attention to the hepatic function, with special imaging, a pathologist involved in decision making and decide which kind of transplant. So this is our group we got now at our discussion. This is a patient with the liver fibrosis, portal hypertension. So this patient needs also liver transplant. And this is how we consider sometimes the FALD meeting, where we discuss everything and we consider liver biopsy to make sure that we know the function of the liver volume, the venous anatomy, if a cirrhosis or something which can be also. And we develop what is called the MELT score. And the MELT score will tell us if the patient, as a predicting endpoint, will need a heart or heart liver transplant. And this is again, combined heart liver transplantation, which I take from some patient, and basically the results show that the heart and liver is acceptable therapeutic option for patients with Feli-Fontan physiology. And this was, you can see the difference in ML score compared from the patient. So it's been postulated that additional liver transplant reduce the risk of post-operative hepatic dysfunction, reduce the bleeding risk for associated liver disease, and growing evidence that cardiac cellular antibody-mediated rejection is less frequent in heart liver transplantation because the liver as a solid organ reduces immunosuppression requirement. And this is the protocol we develop. I don't get you to, this is quite, I would say, boring, because exactly what we're doing when a patient is screened after the age of 14 for possible liver involvement, and we take any significant action. One other thing I want to say, I show this is mainly a complaining slide, that in England and the United States, the UNOS list, and in England, the list from the NHSBT, the category of adult congenital disease is a disadvantage because there are sometimes patients very young, they have limited options for mechanical support, particularly for single ventricle. So, and as the adult population increase, we need to consider to modify the listing status to accommodate these patients. So, and this is basically together with the formalizing transition program from pediatric to adult congenital cardiology, centralizing care of specialized ICH center. If you think that in England it's got only one, and ongoing research for better mechanical support option, particularly for single ventricle. Thank you.
I'm Anna. I'm one of the internal medicine trainees up here in the Northeast. I'm going to talk about something I did as a teaching fellow about 1.5 years ago. So as a little introduction, as a medical student, I tried really hard to see a cardiac arrest. And unfortunately, despite trying very hard, was unable to. And there isn't a lot of data on how many medical students will see a cardiac arrest, but it looks like, from the little data I could, that about 72% of Norwegian students had seen a cardiac arrest, and only just under half had participated in CPR. And from a very brief survey of the students who I was teaching, this appeared to be fairly standard. About half of them seemed to have been involved in a cardiac arrest. There was a lot of fear about it, particularly in the ones who the first time that they might be seeing a cardiac arrest was as an F1 holding the bleep. As a teaching fellow, I had access to a tool called Generate, which I'll go into in a moment. And my idea was to try and see if we could use immersive technology to improve students' confidence. So the whole point of this room wasn't to test how well a student could run or participate in a cardiac arrest scenario. This was purely there to try and give them as true to life experience as possible. So I'll give you a little talk about what Generate is. So Generate is a company. It initially started out doing immersive storybooks for children. So they initially set up in nurseries before transitioning to healthcare. If you look down at the bottom right, you'll see a picture of this is what a typical generate room looks like. So what you can't see is there are cameras which are recording movements. There are lasers again which record people's movements, and there are, sorry, phone next to me is going off, and there are projectors as well which are projecting images onto the screen. So what you essentially have is a room that you can interact with, that you can pipe music into, or you can pipe sounds into. You're essentially in a walk-in computer that you can interact with. And this can create a really high fidelity simulation scenario, which I felt would be a good use of a cardiac arrest simulation. So in order to make this as true to life as possible, what I wanted to emulate was that horrible feeling you get when you're going about your day and the arrest bleep goes off and you've got to go from 0 to 100 in a matter of seconds. So in order to do this, I brought the students into the room and lied to them. I told them that they were going to do an A to E recap, and to the students it seemed as though this went wrong. It seemed like the technology just wasn't working. So I sent them out of the room to try and fix the room, and I simulated a emergency buzzer call and ushered them back in to do a cardiac arrest simulation. The students were just participating. I was running it, so they didn't have to worry about, I didn't want them to focus on could they run it. I wanted them to focus on could they remain calm and demonstrate good skills within the scenario. I also showed them a hot debrief. So after the arrest, we talked a little bit about what had happened and why, and then we went into a mock hot debrief to sort of help show them what that would look like. I gathered my data afterwards by asking them to rate from a scale of 0 to 10 their confidence before and after, and I analysed this data. If you look at the graphs in the middle of the poster, I hope you can see that there is a significant improvement in students' confidence. Interestingly, 2 of the students said after they had 10 out of 10 confidence, which I think is impressive given after 7 years of being a doctor, I'm not convinced I have 10 out of 10 confidence in cardiac arrests, but good work to them. The data did show that there was a significant increase with a mean confidence rate of 3.59, rising to 7.71 after. I also collected some feedback, and it was positive, with people saying that they felt this was a very beneficial experience. I think from this small study of 49 people, I think this is my experience was this was a beneficial way of teaching and getting students to participate in a cardiac arrest. And I think this was beneficial to their confidence, but I do appreciate this was a small study, and I think this is a fair drawback to it. However, I think it's something that is worth pursuing, and I would be keen to continue this to see if this lasts over a few different cycles. So hopefully in a few years I can come back with some more data. Thank you so much for listening. Does anyone?
Good morning, everyone, or evening, depending on the GMT. For me, it's a great honor to present this work today. And our discussion focuses on a question that may become increasingly important in modern valve surgery. And actually, should intraoperative valve size influence choice between mechanical or even biological prosthesis? The current paradigm, traditionally prosthesis selection has been based, and even on the European Society of Cardiology guidelines, basically on age, eventually bleeding risk due to the fact that mechanical heart valves demands anticoagulation and just and only by warfarin, eventually comorbidities and patient preference. eventually. Comparing mechanical or even bioprosthesis, bioprosthesis has better biocompatibility. However, durability is a great drawback. Mechanical heart valves have, if well conducted, excellent long-term durability, designed for last a lifetime. However, requires a lifelong anticoagulation and a strict follow-up. And bleeding risk obviously increases with warfarin anticoagulation. Apart from the fact that effective orificial area is a little bit smaller compared to the bioprosthesis, mechanical heart valves have indeed a good hemodynamic performance. So, what would be the choice? If you take a pretty good look at the guidelines, a major factor is age. However, we have to say that the rapid expansion of transcatheter therapies is fundamentally changing this decision-making process. Going back to 2002, when Kribia performed the first in-human TAVI, transcatheter aortic valve implantation, as an alternative to the surgical aortic valve replacement in a very high-risk patient with aortic stenosis. This therapy, the transcatheter therapy, has grown exponentially. In 2007, the first valve-in-valve was performed by Vanna Master, and that's images from our research, but it's just like that, a bioprosthesis within a transcatheter valve. This was applied to a patient with prohibitive surgical risk for conventional surgery. And I think that we will discuss a little bit later, that conventional operation can add up to 8% the surgical morbid mortality risk. And then another thing, the first in human sequential valve-in-valve was performed in 2016 by Leung. However, it was an emergency context of an unsuccessful valve-in-valve in which the transcatheter valve selected had insufficient oversizing, and another transcatheter valve was implanted in order to avoid migration. And then some selected cases are, by now, some patients are receiving a second transcatheter valve. However, there is important limitation that we will discuss a little bit later as well, that is PPM, patient-process mismatch. It's just like that. If a prosthesis is functioning normally, however, the effective orificial area of this valve is insufficient for the body surface area of the patient, no benefit of the therapy the patient will have. So this is a major limitation for the transcatheter therapies. Considering a lifetime valve strategy and transcatheter therapy, it's possible to imagine that the first surgery is a bioprosthesis. And then, after around 10 years of durability for the bioprosthesis, a transcatheter can be implanted as valve-in-valve. And then, after the generation of this transcatheter valve, that yes, it's still a bioprosthesis, it's possible to figure out a second transcatheter therapy, and even a third. However, is what I call the Matryoshka principle, just like Russian dolls. There is a Russian doll inside a smaller one, inside a smaller one, inside a smaller one. However, the limitation is patient prosthesis mismatch. And for transcatheter therapy, a critical issue is that small annuli may severely limit future transcatheter options due to the fact that we're starting from a smaller one. So, depending on the size of this bioprosthesis, we can figure out sequential valve-in-valve or not. And then, considering what I just said, perhaps small annuli favors eventually mechanical prosthesis, avoiding reoperations, and perhaps larger annuli, even for aortic, as drawn on this slide, or aortic where PPM, patient process mismatch, has a higher risk. Eventually, large annuli may favors bioprosthesis. That's a good question, and that's what I'm trying eventually to answer, or eventually, giving you just some food for thought. So the study hypothesis and scientific basis is based on our research lines, and we based mainly on our in vitro hydrodynamic studies. Some recent literature, there is not many hydrodynamic studies in sequential valve-in-valve, and we have to consider the feasibility of sequential valve-in-valve and the lifetime durability of mechanical heart valves in order to avoid conventional reoperations, repeated sternotomies, cardiopulmonary bypass, and so on. Our experimental model, it is an in vitro. We evaluated the sequential valve-in-valve configurations that I'll show recently using a conventional surgical bioprosthesis, Braille Biomedica from Brazil, and a transcatheter valve, Braille Innovari, that has sizes from 20, 22, 24, 26, 28, and 30 millimeters, the nominal size. And what we evaluated were these topics: effective orifice area, transvalvular gradient, oversizing, and the feasibility of the sequential valve-in-valve. Of course, limitations mainly to the in vitro, not in vivo model, but it can enhance sequential valve-in-valve and the transcatheter therapy for degenerated bioprosthesis. And the tests proposed were this: for aortic position inside 22 millimeter nominal size bioprosthesis, a previous study showed that a 22 millimeters transcatheter valve was the best in hydrodynamic performance, and then inside was implanted a 20 millimeters nominal size transcatheter valve, the immediately smaller, and for the 25 millimeter bioprosthesis implanted the 24 millimeters, that is the best, and this model with the Brazilian valves, and then the immediately smaller and the immediately smaller, and then for the mitral, for studying the mitral sequential valve inside the 31 millimeters, the 30 millimeters has the best performance, and then sequentially a smaller one until up to 24 millimeters nominal size transcatheter valve. And then I'll not show all the details involved, but the results, the resume of all those experiments, we followed the Food and Drug Association rules and International Society of International Organization Standardization rule out 5840. We had a great number of data, up to 180 data of effective orificial area, transvalvular gradient, oversizing for each proposed experimental modeling, and we got up to this. So, in a simple conclusion, we had that sequentially, up to the, in aortic position, of course, up to the 22 millimeters, for instance, in a 25 millimeters conventional bioprosthesis, implanted at 24 millimeters, and then at 22 millimeters, up to the 22 gradient and effective orificial area had good hydrodynamic performance. However, when it comes to 20 millimeters, we standardize as caution because the gradient was adequate, around 20 millimeters of mercury. However, the effective orifice area was around 0.8, 0.9 square centimeters. And then the risk of patient-process mismatch starts up here. And considering transcatheter valves, even the concept of mismatch, patient-process mismatch, is being revisited. That would be a topic for another presentation. However, in the mitral position, up to the 26 millimeter nominal size transcatheter valve, we had a good effective orifice area and lower gradients. And when arrived to 24 millimeters, again, the effective orifice area was a little bit under 1.5 square centimeters, and the gradient was close to 10 millimeters of mercury. So we can figure out what would be feasible. Interesting topic is about the oversizing of a transcatheter valve with another transcatheter valve inside. For balloon expansible transcatheter valves, just as Innovati, the recommended oversizing is about 20%. However, implanting a transcatheter valve inside another transcatheter valve got us observed oversizing around 10%, and no migration of the valves were observed. That's an interesting data. And then this is a personal analysis in which, and considering the data from our experimental modeling, if a patient with a bioprosthesis, 31 millimeters bioprosthesis, after about 10 years, this bioprosthesis would be degenerated, an indication for reoperation. However, is it possible to perform a valve-in-valve and then another 10 years of durability, estimated durability, and after 10 years, a second valve-in-valve could be performed, and then a third valve-in-valve could be performed, and with caution, a fourth valve-in-valve could be performed. So, A patient with who had implanted conventionally a 31 millimeter size bioprosthesis can have up to 50 years free of reoperations, conventional reoperations, or even a higher risk of mismatch. So, considering that, we can say that with the expansion of transcatheter therapies, bioprosthesis will be the best choice. However, if the same patient has a 25 millimeters bioprosthesis, eventually just one valve-in-valve therapy could be possible. So, the decision on the first surgery, which prosthesis, mechanical or biological, would be implanted, should also consider size, considering the possibility of transcatheter therapy. So, it's possible to proceed a lifetime planning for the patient, not only the best option for today, but considering the transcatheter therapy and sequential therapies. However, size of the annuli should be considered. However, this is a large, very large cohort study that demonstrated that the long-term mortality benefit associated with mechanical prosthesis persisted until about 70 years of age in the mitral position, whereas the benefit disappeared after 55 years of age in the aortic position. So, mechanical heart valves are also safe up to 55, 70 years of age, depending on the position. However, the study was performed in a reality that may not be all over the world. The follow-up of anticoagulation with warfarin is pretty different inside a country. Instead, in Brazil, we have some centers that have a good follow-up, and other places that do not have. And this study did not include transcatheter management for failed bioprosthesis. So perhaps this cohort would show that bioprosthesis may have some benefits in long term if transcatheter therapy was included. However, we know that transcatheter therapy is in expansion. For the surgeon, and at the time of the surgery, which prosthesis would be chosen, apart from all the topics pointed in the actual guideline from 2025, shouldn't we consider that larger annulus and the possibility of future valve-in-valve and sequential valve-in-valves would be preferred a biological prosthesis? However, a small annuli, in order to avoid reoperations with a higher risk of mismatch, wouldn't be preferred a mechanical heart valve? Considering that, and considering that mechanical heart valves are safe, depending on the reality of each place, perhaps valve size could be an independent variable in prosthesis selection, not only age, not only patient preferences, or the drawbacks of anticoagulation. And for surgeons, for the ones who proceed with operations, it's a hard task. It takes a little bit more hours, and the risk when calculating an STS score or Euro score 2 can add up to 8%. first operation, second operation, third operation, higher risk of morbid mortality, transfusions, intensive care unit stay, and especially for the aortic position. Is it valid to proceed systematic aortic root enlargement? For instance, a younger patient, 30, 40 years of age, performing a surgical aortic valve replacement conventionally. The bioprosthesis that would fit would be the prosthesis actually would be 21 millimeters, the limit for considering mismatch. And considering the possibility of sequential valve, would it be interesting or not to perform, even if a 21 millimeters valve size is feasible to be implanted, perform an aortic root enlargement? We have some techniques just as Nix or Manungian, anterior or posterior. Both techniques interfere in mitral valve. And then would it be interesting? I don't know. However, I have opinion. We can consider in this patient implanting mechanical heart valve, as the recent large cohort study has shown good benefits until 55 or 70 years of age. The key message for the surgeon is independently, and also just perform that, try to fit the biggest valve possible. The aortic root enlargement in some studies have not shown greater mortality. However, it's substantially bigger time for extracorporeal bypass. So we have an option instead of enlarging, that would be implant a mechanical heart valve. Of course, a very small annuli is necessary to perform enlargement. However, not systematically. That's an opinion, apart from the fact that some centers have good results with aortic root enlargement in the need, when a 21 millimeters prosthesis is not possible to be implanted. So, future directions and consolidations of the transcatheter therapy would require long-term valve-in-valve registries. We have a valve-in-valve registry already in expansion. However, the sequential valve-in-valve is not that big to get some conclusions. Prospective studies would be necessary in order to consolidate, to establish a sequential valve-in-valve as a possibility. The selection guidelines, as I shown in the beginning, could be updated in order to add that the size of the annuli could be included, and also computational modeling and eventually AI modeling may help on this lifetime valve planning, images predicting the size of the annuli, not only at the time of the surgery, but also previously, just as TAVI. When we perform a transcatheter aortic valve implantation, previously tomography is performed and the size of the valve is assessed. So this could be interesting if systematically for these patients, for surgical, our surgical aortic or mitral valve replacement, we could anticipate the size and even some strategies and share to the patient. All these options like the mechanical, you have small annuli, or you can have a biological, so your annuli is big and sequential procedures would be feasible. And some, finally, conclusions and take-home messages. The first one, there is not yet a perfect valve prosthesis. If there was a perfect prosthesis, there wouldn't be two or even studies being performed nowadays. Transcatheter therapies changed this valve prosthesis strategy. The initial size of the prosthesis may influence lifetime treatment possibilities. Small annuli may favor mechanical prosthesis, and larger may favor biological prosthesis, and consequently, valve-in-valve strategies. And the lifetime planning should begin during the first surgery. Ultimately, the valve implanted today determines the therapeutic possibilities of tomorrow, and that's the take-home message. Shouldn't we consider the annuli size, the choice at the moment of the choice, and eventually, previously to the surgery, indeed? Thank you very much, and I conclude with this painting by Borel that is entitled "Escaping the Critics," from the critics. And this is not an attempt of me to escape from any of you. And again, thank you very much.
Well, good morning from US, everyone, and good evening in Malaysia. I'm going to present my work on a functional cardiac output, a ventilation-based measure of cardiac output. I'm located at New Children's Hospital in Delaware. And I'm also assistant professor of pediatrics at Thomas Jefferson University Hospital in Philadelphia. I have nothing to disclose in regard to this presentation. The part of my work is funded my own institute, New Children's Health in Delaware. This is just a graphical presentation of where I'm located on the east coast of USA, near Philadelphia region. And this is the picture of our hospital. I'm going to talk about different topics today. They all lead to one direction, how we estimate cardiac output based on ventilation. I'm going to talk about alveolar functional fraction. I will go in details about that. Why we need to estimate cardiac output in critical care, concept of functional cardiac output, how we have validated in an animal model and in children. First is the alveolar functional fraction. Essentially, it is a perfused fraction of ventilated lungs. So how much, the gas exchange areas of the lungs, how much perfusion they get. In simple terms, it is a ratio of end-tidal CO2 to PaCO2. If you know AVDSF, which is alveolar dead space fraction, that is the equation for that. The alveolar functional fraction is mathematically 1 minus AVDSF. And its value has been studied, and under physiological condition, it is 0.8 to 1. We started our journey towards the functional cardiac output or ventilation-based cardiac output with this alveolar functional fractions study. So I will mention that briefly here. So we studied the ratio of end-tidal CO2 to PaCO2, which we termed as AFF during this study, and compared its relationship with two different group of children with heart disease. The first group was stage 1 surgery after hypoplastic left heart syndrome, where do you expect a fluctuation in QPQS. The second group was stage 2 and stage 3 surgery patients with the same procedures who have less fluctuation of QPQS as such. And these are the results from the study. As you can see, in the group 1, we have 27 patients. Group 2, which is stage 2 and stage 3 surgery, we had 29 patients. As you expect, because it's a stage procedure, the age was lower in the group 1 and higher in the group 2. Here are the QP and QS in both the groups. And as expected, the QP/QS was higher in group 1, which was after stage 1, compared to the control. Controls usually have a lesser QP/QS. When we looked at the relationship of end-tidals of CO2 to PaCO2 ratio to these numbers, this is what we found. So in group 1, you can see this is on x-axis is QPQS and y-axis is the AFF or end-tidal CO2 PaCO2 ratio. And this is the relationship. The Pearson's R was 0.869, very strong relationship. And this is the group 2, where Pearson's R was 0.79, again a very strong relationship. So regardless of QPQS, was it if it's high or low or in the medium range, the end-tidal CO2 to PaCO2 ratio correlate well with this number. And this is combined graphics for all the patients, and you can see the QPQS ratio correlated well throughout with the flow with the end-tidal CO2 PaCO2 ratio. So we kind of established this kind of relationship in a way in this model where end-tidal CO2 to PaCO2 ratio was correlating with QPQS ratio. Subsequently, we tried to study this ratio to assess the clinical outcomes, and again we looked at the outcome after stage 1 surgery, where you can have higher as well as lower QPQS ratios, and study if the end-tidal CO2 relationship, based on that number, if we can predict any outcome. And these were some of the results. So again, small number because this is not a common surgery. So we are in the group 1 where you have, AFF was less than 0.7. This is a small group, and 13. And this is the second group where AFF was higher than 0.7. And we did not see much difference between both the groups, except for time to elector resolution was quicker in children who had a higher end-tidal CO2 PaCO2 ratio or higher AFF. This is another way to present it. You can see this is the group where elected resolution time was much quicker, and this is the group where the elected resolution time was much higher. These were the patient who had high AFF or either low AFF with the end-tidal CO2 to PaCO2 ratio of 0.7. As I moved on a little bit, I kind of transitioned myself to work in primarily a pediatric ICU rather than a pediatric cardiac ICU. I thought about how I can utilize this ratio more to estimate one of our common problem, and that is shock. So again, shock is a very common condition in pediatric critical care. It's about 1/3 of the admission to the ICU, and it accounts for about 50% or more mortality in the ICUs. Cardiac output is an important component of how the shock develops. Shock is a state of imbalance between oxygen supply and demand, and cardiac output is the reason how the body gets the oxygen supply. So it is likely that cardiac output is altered in a state of shock. So we'd assume in current critical care, we would have good method to evaluate cardiac output, but not like our current method, especially in children who are critically ill and in shock, to evaluate cardiac output are limited, especially because most of the current method of estimation of cardiac output, they rely on fixed principle or thermodilution, which are invasive, they're time consuming and not practical in most of the critically ill children. And there are some other newer devices that are also coming into play, but their validation in children from who can weigh from 5 kilo to 80 kilo, it's not that validated yet. So we needed something which is reliable, but we don't have that yet. So we rely on clinical estimates such as heart rate, blood pressure, urine output, mentation, those kind of clinical data. So there remains a need of a practical and reproducible method to understand or to estimate a cardiac output in a critically ill patients, especially in children, where we don't use methods to directly estimate cardiac output that often. So that's where the concept of functional cardiac output came in, and it relied on two different different ideas, which are both related. And the first idea we talked about, the relationship between anti-CO2 exchange and lung perfusion, which I just showed you, which is the relationship between alveolar functional fraction and QPQS. We also know there's data to suggest that end-tidal CO2 numbers is they reflect the blood flow to the lungs in the event of cardiac arrest and pulmonary embolism. So based on this information, we can say that AFF or end-tidal CO2 to pure CO2 ratio has a direct relationship with QP or pulmonary blood flow. Also, we know there's a second idea how we came to functional cardiac output is the relationship between the ventilation and perfusion matching. And we know that ventilation and perfusion, they should match. So how much you breathe every minute should match how much lung is being pumped in your lungs. To mention it in a measurable terms, we can easily say that your minute ventilation should match your pulmonary blood flow. So now combining everything, the understanding of function or the calculation of functional cardiac output can be as follows. So both the things that we just talked about, the alveolar function fraction, how it's related to the pulmonary blood flow, and minute ventilation, how that is related to pulmonary blood flow. If combine both the equation, we can say that multiplication of those two factors. So functional cardiac output could be multiplication of end-tidal CO2 pure CO2 ratio and minute ventilation, which should be equal to pulmonary blood flow. If you think about anyone without intracardiac shunt, that would be equal to systemic blood flow. So you can say that this equation is equal to cardiac output, and that's we named this as a functional cardiac output because our initial terminology was alveolar functional fraction. So we took kept the functional part of it. And you can see all these parameters, end-tidal CO2, PaCO2, minute ventilation, all the parameters to calculate this number are always available in the ICUs as a part of routine care of most of the patients who are very sick and are ventilated and has an A-line in place, and you get a blood gas. So every time you get a blood gas in an invasively ventilated patient, you can essentially calculate this number, which is functional cardiac output. So we took this equation, but it was never tested before. So we started to study this equation first with the animal model, and we decided to study with this hypothesis that functional cardiac output, defined as this multiplication product, has a statistical correlation with cardiac output measured with ultrasound dilution technique, measured with a serostatus device in a large animal model. And our aims for the studies were to validate FCO in this large animal model and to validate FCO in this large animal model under normal condition and during shock. So we collaborated with a colleague who was doing experiment on a pig model. So in this study, this experiment, the pigs were being sedated, invasively ventilated with a tracheostomy, central line and arterial line were placed. They underwent a measurement of baseline cardiac output with ultrasound dilution technique. Once the measurement was completed, they were given lipopolysaccharide as an endotoxin to induce shock. And once the criteria for shock were met, all the experimental pigs underwent 5 other measurements of ultrasound dilution cardiac output. So there was one cardiac output measure was available with each several times in each pig. And every time the pig underwent measurement of ultrasound dilution cardiac output, there was a ABG done. And we already had data for minute ventilation and end-tidal CO2. So we could calculate our variable of functional cardiac output each time the ultrasound dilution was measured. So our reference standard ultrasound dilution technique, I will briefly mention you. So this is our pig undergoing the study. You can see the pig are tracheostomized with the endotracheal tube, has a blue, which is the central venous line, and the red is the arterial line. And this is the ultrasound dilute or the CO status device that measures the ultrasound dilution cardiac output. This is the pump where you pump the normal saline. These are the two sensors which generates ultrasound dilution curve, and you measure the cardiac output. Statistical plan, we based on our initial interim analysis, we felt 35 pairs of two values would be sufficient to get our analysis done. And our plan was to undergo a repeat measure correlation, blend, and equivalent analysis. These are some of the results. As you can expect, so we studied 7 pigs, total 40 measurement, and these are some of the baseline variables, and these are the 2 cardiac outputs. So you can see at baseline state, as expected, the numbers were higher, and shock state numbers were lower for both the output. And then we did some validation studies. The main validation we did is repeat measure correlation, where in this graph, you can see on the x-axis is the FCO, and on the y-axis is ultrasound dilution cardiac output. The pigs are different pigs are in a different color, and each pig followed their own curve, but that correlation always stayed because of the R was 0.74, so which was a very strong correlation. So now we had this results, so we decided to take it further. Once we had this animal model confirming that we have correlation, we decided to study to validate it in children. And again, same hypothesis we undertook, that FCO has statistical correlation with some measures of cardiac output in children without intracardiac shunt. And our aim 1 was to validate FCO, again, thermodilution cardiac output in children who were undergoing elective cardiac catheterization, because these children were ventilated with invasive ventilation and had A line in place, and there was a ABG done. And also the second group we took was children who came to the pediatric ICU, not the cardiac, the pediatric ICU, who were previously healthy, underwent a surgery and had invasive ventilation and A line, to compare the functional cardiac output measurement with cardiac index based cardiac output with normal cardiac index of 3.25 liter per minute when they are near physiological baseline for the cardiorespiratory status. And I will explain a little bit more how that worked out. So it was a retrospective observational study. These are our study groups. So group 1, as I said, children undergoing the diagnostic cardiac catheterization with measurement of thermodilution cardiac output. The group 2 were children without known heart disease in the PICU, and these were the physiological baseline, PEEP of less than 7, FR to less than 30%, heart rate parameters for younger and older kids, and not on any vasoactive. So they were supposed to be on cardiorespiratory baseline when we measured the FCO, so that we can compare to a standardized cardiac index based cardiac output. Again, the statistical plan, we felt 28 patients would be sufficient. We are planning Pearson correlation. We did 1,000 times. We repeated the value 1,000 times with the Monte Carlo simulation to stimulate random values of around the mean of 3.25 liter per minute for each kid. So that make sure that, because cardiac output would vary a little bit all the time. So to simulate that, we did the simulation in our analysis. We also undertook bland and pet plot for agreement and equivalent test to assess for equivalence. Again, similar information. We had total 133 children, 130 cats from 22 children. There are some exclusion, 80 pair in group 1. Group 2 in the PICU children, we had 59 initial children out, and in the end we had 31 pairs available for analysis. 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 31 pairs available for analy These were our result slide. So these are two different groups. One is cardiac catheterization group, another is the PICU patients. They're completely two separate groups. The first one had diagnosis of cardiac transplant as the most common diagnosis. The second group has neurosurgery as the most common diagnosis. And you can see the values of both the cardiac output. So reference standard was thermodilution in group 1, and the FCO was our study variable. In group 2, again, FCO is a study variable, and cardiac index based cardiac output was the reference standard. So correlation, which assesses the strength and direction of agreement, or strength of direction of correlation between the two values. Again, this is our correlation line, and the R value, the correlation coefficient was 0.64, which is moderately strong for the group 1. For group 2, it was 0.93. So very strong correlation between at that time. We also assessed the bland and pit plot, which assesses the agreement between the two values. It has on the x-axis is the average of each pair, and on the y-axis is the difference between each pair. And what we try to assess with bland and pit is the bias. The mean bias was 0.17. In the group 2, the mean bias similarly was negative 0.027. So very small mean bias. We also undertook equivalent test to assess how tight the agreement is. So in group 1, the mean of the ratio between the two value was 0.97 with a standard error of 0.303. And you can see these are the agreement lines, the dotted lines, and the confidence interval lie very closely within the lines. And similarly in group 2, these are the two equivalence lines, and this is our confidence interval very tight, very close. So to conclude, this is the equation of functional cardiac output minute ventilation multiplied by end-tidal CO2 to PaCO2 ratio. It's a pragmatic measure of cardiac output in critical care. We were able to validate it in animal model, also in human model, in a standardized patient, not in a critically ill patient or actively changing patient, but in a standardized patient. And we found some strong correlation. The next step would be to study this with the clinical outcome, and that is our plan to study, associated with clinical outcome in ICUs. And I thank you for all my collaborators for all these projects over a period of time. I'm happy.
Thank you for the opportunity to share our research in this presentation titled Pumps and Pathogens, Risk of Sepsis in Mechanical Circulatory Support. So today I'll be discussing infection and sepsis as a major complication in patients requiring mechanical circulatory support. So despite advances in device technology and critical care management, sepsis remains one of the most significant contributors to morbidity and mortality in this population. In this presentation, we'll first review the burden of infection and sepsis in mechanical circulatory support patients and why early recognition is so important. We'll then look at the risk factors identified through ensemble machine learning models, which allowed us to evaluate complex interactions between patient characteristics and clinical outcomes. Then we'll discuss the physiologic relationship between congestive heart failure, prior cardiac surgery, and increased susceptibility to sepsis. These factors create a unique inflammatory and immunologic environment that may predispose patients to infection during MCS support. And finally, we'll explore how these findings may influence bedside management, risk stratification, and prevention strategies with the goal of improving outcomes in this critically ill patient population. So why study sepsis in MCS? Patients who require MCS are among the most critically ill patients in the ICU. They often require multiple invasive devices, including central lines, arterial lines, temporary pacing wires, cannulas, ventricular assist devices, and mechanical ventilation, and all of which increase their risk of infection. In addition, these patients frequently experience prolonged ICU and hospital stays, creating a significant exposure to hospital-acquired infections. Their underlying shock state, inflammatory response, and immune dysregulation further increase susceptibility to sepsis. Previous studies have already demonstrated infection rates ranging from approximately 18 to 20% in MCS patients, which highlights that sepsis is not a rare complication, but rather a common and clinically significant problem. Because sepsis contributes substantially to morbidity and mortality, length of stay, and healthcare utilization, identifying which patients are at the highest risk is essential for earlier intervention, prevention strategies, and improved outcomes. This table outlines the number and types of mechanical circulatory support devices included in our patient population. We have them categorized as acute and durable MCS therapies. Acute MCS devices are typically used for refractory cardiopulmonary failure and provide a temporary hemodynamic support during critical illness or bridge to recovery, decision-making, or advanced therapies. So in our cohort, this included our intra-aortic balloon pumps, our Impella devices, tandem heart systems, ECMO of all modes, biventricular assist. So sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host. So moving on into our study objectives, we aim to identify pre-procedural comorbidities associated with the development of sepsis in patients requiring mechanical circulatory support. To accomplish this, we utilize ensemble machine learning and decision tree modeling, which allows us to evaluate complex interactions among multiple patient values and identify patterns that may not be detected through traditional statistical approaches alone. So following IRB approval, we conducted a retrospective analysis at Ochsner Health Jefferson Highway campus from January 2017 through October of 2023. This study included 199 patients who received 244 mechanical circulatory support devices. For patients with durable or destination devices, data collection focused specifically on post-operative period from day 0 to post-operative day 14 following implantation. This time frame was selected to better align and compare outcomes with patients who receive an acute or a short-term MCS therapy. This included adults 18 years or older, and we evaluated 14 pre-procedural comorbidities. And within our cohort, the diagnostic evaluation for sepsis included both clinical and laboratory criteria. So clinically, we assessed for signs such as fever, tachypnea, tachycardia, hypotension, altered mental status, and other indicators of organ dysfunction. Our laboratory data included complete blood counts, point-of-care lactate levels, renal and hepatic function testing, arterial blood gases, and blood cultures, sputum cultures, urine cultures. So together, these variables allowed us to comprehensively evaluate the relationship between pre-procedural risk factors and development of sepsis in the MCS population. And these are the comorbidities that we analyzed. And so regarding our statistical approach, we used ensemble machine learning methods to identify which pre-procedural comorbidities that may predict the development of sepsis in patients who receive MCS. So specifically, we applied bagging and random forest modeling techniques to evaluate variable importance and determine which factors carried the strongest predictive value. The further clarify statistical relationships between these variables and sepsis incidence, we then incorporated decision tree analysis. This allows us to better visualize interactions among risk factors and identify clinically meaningful patterns within our data set. Model performance demonstrated a C-index of 0.76, which is good predictive discrimination, and our misclassification rate was approximately 19%. And all of our analyses were performed using the program JUMPed Pro. Now moving on to our results. The overall incidence of sepsis within our study population was about 20%, with a 95% confidence interval ranging from 16 to 26%. This finding was highly comparable to previously published literature, including the meta-analysis by Rajic and colleagues, which reported an infection incidence of approximately 18% in mechanical circulatory support patients. We examined infection rates across different device types, durable devices, some of our highest infection rates within our cohort. And although our current analysis did not specifically categorize infections by individual device subset, this remains an important area of interest and is on our radar for future investigation as additional data is incorporated into our database. But overall, these findings reinforce that sepsis remains a common and clinically significant complication across the MCS population, regardless of device strategy. So after completing the ensemble machine learning analysis, two factors emerged as being the strongest associated with an increased risk of sepsis. The first was having a history of congestive heart failure, and the second was a prior cardiac surgery history. So patients with either of these demonstrated a significantly higher likelihood of developing sepsis while receiving mechanical circulatory support. These findings suggest that chronic cardiac dysfunction and prior surgical exposure may contribute to an already heightened inflammatory and physiological burden before MCS is even initiated. In terms of model performance, our machine learning model demonstrated good predictive capability with a C-index of 0.76 and a misclassification rate of 19%. This supports the reliability of the identified predictors and highlights the potential role of machine learning in improving early risk stratification for sepsis. So next, we further explored these significant pre-procedural comorbidities using decision tree analysis to better understand how these variables interact with one another. Interestingly, the analysis demonstrated that patients without a history of coronary artery disease, but a prior history of cardiac surgery had a highest incidence of sepsis during MCS with an approximate rate of 60%. In comparison, patients with both coronary artery disease and congestive heart failure demonstrated a lower incidence, approximately 18% of sepsis during MCS support. So these findings suggest that the interaction between baseline cardiac disease and prior surgical exposure may influence sepsis risk differently than expected. Prior cardiac surgery may represent a marker of repeated physiological stress, immune dysregulation, adhesions, reentry complexity, or just prolonged exposure to invasive therapies, and this all will increase your vulnerability to infection. So overall, the decision tree analysis helped highlight how combinations of comorbidities, rather than just isolated variables alone, influence sepsis risk in this critically ill population. And I apologize for this busy table, but this depicts the decision tree analysis results and shows how the individual comorbidities are combined to create different risk profiles. Here, this table demonstrates contingency analysis evaluating the association between sepsis and congestive heart failure patients. Among the patients, a history of congestive heart failure, 32 patients developed sepsis, while 77% did not. In comparison, patients without congestive heart failure had a lower sepsis incidence, approximately 17%. Although both groups experienced sepsis, the higher percentage observed in the congestive heart failure population supports our machine learning findings. This may reflect the chronic inflammatory state, impaired tissue perfusion, end organ dysfunction, and immune dysregulation commonly seen in advanced heart failure patients prior to MCS implantation. And here we have the contingency table evaluating the association of sepsis and previous cardiac surgery in patients receiving mechanical circulatory support. So among patients who had a history of open heart cardiac surgery, 21 patients developed sepsis. All 60 did not. In comparison, among patients without prior cardiac surgery, only 17% developed sepsis. Overall, this demonstrates a noticeably higher incidence in patients with a prior surgical history, further supporting what we observed in the machine learning and decision tree analysis. These findings suggest that previous cardiac surgery may be an important pre-procedural risk factor when assessing susceptibility to infection during MCS therapy. From a physiologic standpoint, congestive heart failure already creates a pro-inflammatory state that closely resembles aspects of septic physiology. Patients with reduced ejection fractions often demonstrate elevated inflammatory cytokines and activation even before the infection occurs. So this baseline inflammatory profile may particularly explain why congestive heart failure patients appear more susceptible to sepsis during MCS. In sepsis, inflammatory mediators increase nitric oxide synthase activity, which leads to an excess of nitric oxide production. This process impairs intracellular calcium handling within cardiomyocytes, and so ultimately this is going to reduce your myocardial contractility. Clinically, this becomes particularly significant in patients who already have poor systolic function and limited cardiac reserve. And so as a result, managing these patients becomes extremely complex, especially when it comes to fluid resuscitation. Providers must carefully balance the need for adequate perfusion and sepsis management while simultaneously avoiding fluid overload and worsening cardiovascular compromise. So the overlap between septic physiology and advanced heart failure highlights why early recognition and individualized management strategies are so important in this population. For our cardiac surgery patients, an increased risk of sepsis during MCS, the postoperative scar tissue in areas of poorly perfused tissue acts as a potential infection nidus, and because these scar zones often have reduced blood flow, they may also have a decreased immune surveillance, which makes the body have to work a little more to effectively respond to bacterial contamination or infection. In addition, many of these patients undergo complex reoperative or redo surgeries. A repeat sternotomy and prior surgical alterations can increase the complexity of the procedure, create additional challenges during a device implantation or cannulation. And these patients are also frequently in a chronic pro-inflammatory state due to long-standing cardiovascular disease, repeated surgical stress, and ongoing tissue injury. So together, these factors may help explain why prior cardiac surgery emerged as an important predictor of sepsis within this population. And finally, we acknowledge several important study limitations. This was a single center study, which may limit the generalizability of our findings to other populations and practice settings. Our sample size was relatively limited, and as with all retrospective studies, documentation bias is also possible. But despite these limitations, the use of ensemble machine learning represents a key strength of this analysis. These methods are particularly powerful in managing complex multifactorial data sets and may help mitigate some aspects of confounding that are common. Overall, ensemble learning techniques can complement traditional statistical methods and may offer improved performance when analyzing highly interrelated clinical variables. From a clinical standpoint, these findings have several important implications. So first, patients with congestive heart failure and a prior history of cardiac surgery should be identified early as higher risk populations. Second, there may be value in optimizing the inflammatory state prior to MCS implantation when feasible. And third, a strict adherence to infection prevention bundles is essential, including standardized line care, device management protocols, and early removal of unnecessary invasive devices when clinically appropriate. And finally, these findings support the potential development of machine learning-based risk stratification tools or clinical dashboards to help identify high-risk patients early on in their course. And looking ahead, future directions for this work include expanding to a multi-center study design to improve our validation and enhance generalizability across different institutions and populations, and incorporating inflammatory and sepsis biomarkers such as C-reactive protein, interleukin-6, and procalcitonin may further improve model accuracy and clinical relevance. And our future work may also focus on developing a dynamic, real-time machine learning model capable of continuous sepsis risk prediction at the bedside. Finally, there's potential to evaluate targeted anti-inflammatory or preventative strategies in these patients, which could ultimately help reduce infection rates and improve outcomes in patients receiving mechanical circulatory support. And in summary, our sepsis incidence was 20%. Our patients with congestive heart failure and prior cardiac surgery emerged as the two significant comorbidities. We had good machine learning model accuracy, and we emphasized prevention and early identification of sepsis.